Welcome to everybody this evening. Thank you for your time. I know that time is precious these days. We don't have a lot of it. And a very big welcome to Dr. Michael Tang. Thank you for your time this evening. So we've got a wonderful webinar hosting for you tonight. We've got a lot of people on this evening. I think we are sitting at about 250 odd registrations, which is wonderful. So EthOss's upcoming events are on the screen for you all to see. September is a busy one with September the 10th with an immediate dental implant protocol in Cairns. Then we've got AMSOMS, which is also in Cairns, and then we run into PET in the Gold Coast, and then you've got the Versa, then you've got AOS, ASP, APS with Arc Health at stand 15 and Southern Implants at 19 and 24. Then you've got 3 events in October. You've got a Versa, you've got the AIM, and then you've got the Cadaver Workshop. So EthOss is spreading its wings all over the place, which is lovely to see these days. So if you can think of an event, generally speaking, EthOss will be there. Where can you purchase EthOss? Arc Health is one of the suppliers, City Dental, Matrix, Medident, Southern Implants Australia, and VP Dental. So a little bit of housekeeping for this evening. Please feel free to put all of your questions, and we do encourage any question. There's no silly questions. To please place them in the chat box. We will have a live Q&A after Dr. Tang's presentation. So if you've popped a question in or you want to hang around for the questions, please do so. He'll be answering them live as long as we don't have too many of them. If we do run out of time and we have too many, we will get them written answers emailed out to you. So please feel free to put as many in as you need to. CPD certificates, we will aim for delivering them to your email within 5 days. The recording the same. After the webinar is finished this evening, a short survey, a very short survey will go out. Please take a minute of your time to give us your feedback. It's really important. And if you also want to receive the EthOss newsletter, please tick the box in the survey to receive that. That will keep you up to date on where EthOss is, what it's done, what it is doing, and then educational things that you may want and other things that come up. It's also a really handy tool. So without further ado, I'll thank everybody, but thank Dr. Michael Tang for your presentation that you're about to take, and I will hand it over to you. I will stop sharing and you can take over.
Thank you, Ash. Let me just get this all set up. And Ash, you can confirm to me whether or not you can see my presentation.
I sure can. Looks great.
Yeah, right. Just give me a second. Okay, get this all second here. Yeah, can you still see okay?
Yes, it's perfect.
Okay, so thank you for the kind introduction, Ash, and thank you to W9 for the invite to speak on today's webinar on immediate placements and full arch treatments. Now, in my daily practice, 99% of the implants that I place are Southern implants, and 99% of bone grafting that I carry out is done using EthOss. But just to clarify that although I will be talking about these products today, I am not in any way financially affiliated with either company. And what I'll be talking about are simply my experiences on how I use them for my cases and how they work in my hands. So for those who don't know, I'm from Scotland, and if you haven't been to Scotland, I would highly recommend trips to see some of our beautiful scenery from, Fort William, the Forth Road Bridge, which in fact is the longest suspension bridge in the world when it opened in 1964. Or even the Jacobite steam train, which was made famous by the Harry Potter series. I was born and bred in Glasgow, a city that I love very much. Although it would be nice if we had some of the Australian sunshine and less rain. And why wouldn't you love Glasgow when it has the Duke of Wellington with a traffic cone on its head as the unofficial icon? Now, before we start, I'd like to tell you a little bit about my background. So I qualified in 2002 from the University of Glasgow, and dental implants was one of those things in dentistry that really fascinated me. Back in the day, education on implants was very limited. But in 2004, I started attending various commercial courses, weekend courses, these so-called intensive week-long courses, and I found myself a really good mentor and started placing implants. I currently own about 6 dental clinics and around 90 members of staff, and pre-COVID, I used to travel around 10, 11 different clinics carrying out implant treatment at those sites. But of course, COVID changed many things. It changed my working pattern, and now I only practice at the Caliani Dental Lounge in the centre of Glasgow. As well as clinical practice, I also teach an MSc, a Masters in Dental Implantology course for the University of Central Lancashire, and I also run my own implant year course as part of the Scottish Dental Academy. The format of today's webinar is very informal. We will cover the topics of immediate placement, then full arch treatments, mainly showing you my own clinical cases and how I manage them. So I feel that's the best way to pick up practical tips, especially since we have 2 large topics to cover within such a short time. And then at the end, hopefully we'll have about 15 minutes or so for some questions. So I mentioned Southern Implants and EthOss. Why do I like using Southern Implants, especially for immediate placements? Well, Southern Implants has something called the coaxis implant. So the coaxis implant to me is a game changer. You'll see on the top left-hand side of the screen, you have an implant, but you have the prosthetic screw at a slightly different angle. Now, immediate placements are most commonly done in the aesthetic zone, so the anterior maxilla. The anterior maxilla, in most cases, will have a slight kind of proclination to the ridge due to the natural anatomy. So to be able to insert the implant in the ideal surgical position where the bone is, very often you have the prosthetic screw coming out the incisal of the crown, of the future crown, or maybe even the buccal labial position. So in the photographs there, you'll see a blue carrier, and the blue carrier indicates the angle at which the implant has been inserted. And then you'll see a driver, and the driver is currently inserted into where the prosthetic screw channel is. So that is where your screw retention access for the crown will be. So the insertion is almost incisal, but this prosthetic screw channel is palatal. So that gives you the option to insert the implant in the ideal surgical position, but still be in the ideal restorative position for a screw-retained prosthetic prosthesis. And in turn, this can reduce the need for bone grafting or the volume of bone graft required. Another reason why I like southern implants is that they have many different site-specific implants. And for immediate placement, the inverter is hard to beat. The inverter has a body shift design where the mid portion is really wide and it has this aggressive taper towards the apical aspect for high primary stability. And then we have the coronal portion, which is about 1 millimeter narrower, and that allows an adequate jump gap. And this is therefore this chamber for bone growth. All studies for immediate placement highlight the importance of having an adequate jump gap, and filling this jump gap is crucial. So you'll see in a diagram here, apologies for the slight blur, you have this aggressive taper inserted into where the host bone is for high primary stability, and it narrows down in the coronal aspect for your bone graft to be placed. And why do I like using EthOss? The key reasons for me is true post-bone regeneration. It is not just a space maintainer like a lot of other graft materials. It actually becomes bone. EthOss is also fully resorbed and replaced by healthy bone in about 18 months. So there's no foreign materials that remain after this time. So this allows the site to remodel and turn over into new bone over time, adapting to the loads placed on it by the dental implant and the occlusion. And I find it really easy to use without the need of a membrane. So EthOss comes in a plastic syringe applicator, and it's mixed into a paste with saline. Some people love the syringe and some people don't. I've tried using the syringe only. I've tried expressing it into a Dappins dish and using it that way. And I suppose there's a bit of personal preference. But overall, the product is straightforward to use and to apply. And as I said, doesn't require an additional collagen membrane. We know how fiddly these membranes can be. So not using a membrane is definitely a plus. And it's 100% synthetic. I think in this day and age, if you give the patient an option, many would prefer non-animal products. They would prefer synthetics. So the fact that this is 100% synthetic is fantastic, and it eliminates any risk of cross-contamination. Now, there are hundreds of synthetics, all these putties and gels. So why EthOss? As I said, it's clean. It's a very pure material. Contains just two components, the beta tricalcium phosphate and the calcium sulfate. So two components, roughly 1/3 calcium sulfate, 2/3 beta tricalcium phosphate. And the benefit of having this calcium sulfate is that it's compatible, it's stable. Its function is to create a barrier. So this is what makes the EthOss membrane free, if you like, and it stabilizes the graft. And it absorbs slowly over a few weeks. And what this does is it creates little holes for bone, blood vascular ingrowth. And it provides nutrients for the mineralization. Now, in the past, we taught users, when I ran EthOss courses 2-3 years ago, we taught users to mix the EthOss with saline, wet it, and then express the excess saline onto a piece of sterile gauze. What we found was this wasn't the optimal way of mixing and using EthOss, because mixing the EthOss in too much saline dissolves the calcium sulfate And then you express the excess onto the gauze, means that we lose some of the calcium sulfate onto that piece of gauze. So we've lost some of what is required for the EthOss to set and bind. So I've had many users ask me over the years why EthOss doesn't seem to work in their hands, or it's unpredictable. Sometimes it doesn't set. I've placed the gauze on for 5 minutes, 6 minutes, it doesn't set, or it just all disappears and it doesn't work. And the key is using it and mixing it properly. So the first thing you want to do, oh, sorry, apologies. The first thing you want to do is to pull the plunger down and loosen the particles. Because during shipment and transportation, the EthOss, the beta tricalcium phosphate and the calcium sulfate, compacts within the syringe, and all the kind of vibrations during transport can actually separate the components. So it's really important that we loosen what's in the syringe by pulling the plunger back and loosening it. And then you want to rotate the syringe, back and forth to actually just make sure it's mixed well. Now, what we don't want to do is flood that tube, flood the syringe with saline. You want to add just the right amount. Now, the right amount for a 0.5 cc syringe is about 6 drops. So from experience, we've tried to work out what the ideal is, and it's about 6 drops. So what you can do is you can actually fill a syringe, an endo syringe or whatever syringe you prefer, with saline and drop slowly 6 drops into the syringe. What I'm showing you is how I do it, because I've used it so many years and so often on a daily basis that I just use my handpiece, and I kind of know just a few drops, okay? Just a few drops. And then I mix the EthOss within the tube into a paste. So that's how I would do it. So mix it into a thick paste, or a paste to a consistency which you like using. Right, okay, so got a couple of interesting papers. This is mostly practical slides, but we need to know a little bit about the science and background on EthOss. So a very, very interesting paper. This compares alloplasts with xenografts and allografts. And what this paper shows is that the bone healing is significantly better with the EthOss group. And over 2 weeks, over 6 weeks, what we find is that bone healing is much quicker and with less graft material. So this is where the actual regeneration comes in. So it's not just new bone, but the fact is EthOss bioabsorbs and slowly becomes real host bone. And even in 2 weeks, all the histology shows that the osteoblast markers, the OPG, is significantly higher in the EthOss group compared to the other groups. Now, Gregory Steiner, who's the director of the Bone Institute, made a quote once and said, well, the difference between augmentation and regeneration is that bone can be augmented with anything. You can shove anything to kind of plump up and space maintain. But to truly regenerate bone, the material that you use, first of all, must be biocompatible, but also fully resorbable. And that results in regeneration. So the bone growth must equal what is lost from the graft material. And you can see from this slide, the purple is a typical xenograft slide, where you see these large graft, GR is graft, these graft particles, remain, and NB is new bone, compared to the EthOss group, where the graft starts to go away much quicker with a larger area of new bone within the same time. And for those who use xenografts in the past or currently still use xenograph, if you ever had a failed implant or have to go back into a surgical site, even after many years, you will notice the xenograft is still present many, many years later. It basically is dead bone sitting there, not really doing much, and there's never really true regeneration. And another slide here, and you'll see an implant in place. And this patient had some buccal bone grafting with a xenograft. And it looks nice. It's very radio opaque, but it sits there and it looks very different to host bone because it's very dense and dead. And again, going back into a surgical site where xenograft has been used, you always see these little chunks, these little granules of bone still present. Now, using EthOss, no membrane is required, as I mentioned, and this means that we have the periosteum in full contact with the graft. And the periosteum has many, many immense regenerative potential components. Many studies have shown that the periosteum, is highly vascular. It contains within the periosteum osteoblasts, progenitor cells, stem cells, and in all age groups, the cells of the periosteum retain the ability to differentiate into osteoblast and produce bone. So having the periosteum as the membrane is far better than a dead piece of collagen. So I have briefly gone over why I use the products that I do for my daily clinical practice. And now we'll move on to cover the immediate implant placements and show you a couple of interesting and complex cases. Historically, dental implants were predominantly placed in a completely healed site. That's the way I used to do it when I started placing implants about 20 years ago. I actually took a tooth out and waited 6 months for as much healing as possible before placing the implant, and then I waited another 4 or 5 months before I started loading. So the whole process took a year or over a year. But nowadays, of course, clinicians have an important choice to make when selecting the timing for implant placement between these 4 treatment options. So you've got the type 1, which is the immediate placement. You've got type 2, which is the 4 to 8 weeks. So it's a little bit of healing, or soft tissue healing, but the bone's not fully healed yet. Or the type 3, which is very common, and that is you've got some bone healing, soft tissue healing already, and then, of course, the type 4, which is like a delayed healing. Okay, the delayed healing. Now, unfortunately, when it comes to the timing of implant placement, the one-size-fits-all approach cannot be taken, which introduces challenges to the clinical decision-making as soon as a tooth is planned for extraction. Based on systematic reviews, there is no specific recommendation in the literature as to say which protocol offers the best aesthetic outcome. So something that works for you may not work for others, and so on and so forth. But the current literature also does not favour specific timing and loading in terms of implant survival. So it's not a case where immediate placements don't last as long and delayed placement is the best long term. There's no evidence to suggest one is better than the other that way. So it is up to the clinician to weigh up the pertinent biological and anatomical and aesthetic factors before deciding on which approach is best for that patient. For me, in my hands, there are 3 main reasons for immediate placement. The obvious one is reduced overall time, reduced number of invasive procedures for the patient, less injections, less visits. The extraction and surgery is carried out at the same time. And although there's no evidence to suggest which is better, in my hands, immediate placements give me a better aesthetic outcome. So this is the risk assessment criteria for implant placement by Lambert et al. In 2023, which is part of the ITI treatment guide. This is very important, this slide, as it helps decide whether we should consider immediate placement or not, or how predictable the outcome will be. The level of risk and complexity you are willing to take when carrying out treatment very much depends on your experience and willingness to deal with the potential issues if and when they arise. I have colleagues who carry out immediate placements in low-risk patients only, and that is okay. But like most of us, as we become more comfortable with a certain procedure, we tend to start pushing boundaries. Okay, so we've got, crudely speaking, for the criteria for immediate placements is everything in the green column, the low risk. So you want good gingival phenotype, you want a lot of bone for primary stability, you want a lot of labial or facial bone, it's all the obvious stuff, good periodontal health. So, and then of course, on the other hand, the high risk is all the opposites, the lack of bone for stability, the poor type of gums, and so on. So I'll move on to show you some cases. This is a young patient. It's an immediate central incisor. It has a periapical area and a high smile line. So she has a history of trauma. She was hit by a door. I think she was messing around when she was about 15 or so. She fractured the tooth in the upper left central incisor. It required root canal treatment. And 5 years ago, it required another root treatment. And now there's kind of low-grade symptoms. She's feeling the tooth a little bit grumbly, a little bit unpleasant. Every now and again, she feels a little swelling in the apical area. And throughout the years, it was patched up with composite. So she's not happy with how it feels, and she's not happy with how it looks. And having discussed all the usual options, she's decided to proceed with dental implant treatment. So when we initially look at this case, it may seem to be a very difficult high-risk case. But when we break it down, we realize that there are some medium risk criteria, high risk as well, but actually predominantly low risk. So what do? We carefully remove the tooth with some periotomes, luxators, and forceps. But as you can see, I've managed to pinch a little bit of the gingival margin, which is not ideal. But very often now, I use the Benix tooth extraction device in my practice, and this would have actually prevented pinching of the gum. So this system consists of the actual extractor pulley, some screws, some drills, and actually kind of almost like a pulley rope system here, which I'll show you. So this is not the same patient, but if you wanted to use a system like this, which would be probably recommended to prevent the damage to the gums or the bone, you would first of all decoronate the tooth. And then you would prepare a channel using the appropriate drills in the kit, and then insert the screw. You want to use some periotomes around the tooth to break up the periodontal ligament as much as possible. And you would use the extraction system with the pull rope, which hooks into the screw, and the other end hooks onto the Benix extractor. And by almost tightening that pull rope, the tooth or the root is extracted very, very atraumatically. Now, it's essential when we're doing treatments like this, or any implant treatment, is to clean any infection. Now, I don't like working down a socket in a case like this where I know there's some periapical infection. So I do raise a flap in situations like this, but I try not to disturb the gingival margin. So in this case, we left the attached gingivae and the gingival margin untouched, and the incision line was carried out across the mucogingival junction to minimize the appearance of any scar tissue. So by doing this, I can now access the apical area to thoroughly clean the site and effectively and predictably graft the affected site as well without disturbing the aesthetics of the gingival margin. Now, I like to use these degranulation burrs and using sharp instruments as well. So these degranulation burrs are great, at softening and, roughening up the soft tissue. And then you can actually use any carets or bone removers to actually scrape off the rest. So now I can actually insert these degranulation burrs down the socket, but actually directly over the periapical area as well. So when using EthOss, it's absolutely essential that all soft tissue remnants is completely removed. You want EthOss directly onto clean, hard bone. So now everything looks nice and clean. So I proceed to prepare the osteotomy sites. The guide pin you see here inserted into osteotomy site, it's actually a 12-degree guide pin. So this is part of the Southern Implants coaxis kit. So it's inserted and it shows you the ideal prosthetic screw channel for the crown. In this case, what I did was I placed some EthOss into what would be the jump gap once the implant is placed, but I placed that first, and I place a little bit of EthOss into the apical area region. I do that before I place the implant. And then I insert my inverter implant, the coaxis. So that is obviously the implant, and the screw channel is off at the sides, the 12-degree angle. And once again, another image showing the coaxis in place, and the blue carrier is the implant insertion angle, and the driver is where the screw channel will be. I place a healing abutment, and then graft the jump gap as well as the periapical area. I proceed to make my temporary crown. Of course, the emergence profile of the temporary crown is really important on how you manage the soft tissue margins. And that's a temporary crown in place. Now, in cases like this with the high lip line, it's essential that you either use a temporary crown that can maintain the gingival margin as it was, or at least make the gingival margin slightly more incisal and then manage it by compressing it and pushing it back up to the correct level. So in this case, we made a temporary crown which will allow the gingival margin to drop a little bit and allow me to control it back up. So in place, sutured up, nice screw access position, and that's the post-op periapical. Now, this is 10 days after surgery. So sutures removed from where we access the periapical infection. The soft tissue healing is amazing with EthOss. Notice the gingival margin here is now a little bit lower, as I mentioned, than the upper right one. And that's all due to the shape of the emergence profile and of the temporary crown. And look at how plump the buccal aspect is there and how nice and healthy that soft tissue is. So 3 months later, look at the soft tissues. Again, it's well maintained. Buccal contour is amazing. We always talk about upregulation with EthOss, and that is what it's all about. It's about improving the soft tissue quality. What I tend to find that is that if there's good attached gingivae present, EthOss makes it better. But yes, the gingival margin is still lower. So at this stage, what I did was I changed the temporary crown, which I fitted at the immediate placement stage, with another temporary crown to correct the emergence profile, improve the gingival contour and morphology of everything. So you'll see that the gums are blanching because we are now shaping the gums. And at fit stage, we see here that the gingival margins of the final crown is level with the adjacent central incisor. So in a 1-year review, everything is quite stable. So under the ITI immediate placement risk assessment criteria, which I showed you, this was mainly a low risk case, but nevertheless, it's a challenging case with the high lip line, with the infection that's present. and the history of, more than one root canal treatment. But through a methodical step-by-step approach, cases like this can be managed effectively with immediate placement. But note the mesiodistal width here of the two central incisors are slightly different. So in hindsight, maybe I should have used some composite bonding on the upper right one, maybe widen it a little bit before making the final. But hindsight is a great thing. But nevertheless, a very nice result. Now, this is a new case, which is not fully completed yet, but a really interesting case because it demonstrates what can go wrong with immediate placement. So this patient came to me, referred to me, not happy with the FP3 style crown and a high smile line. So the FP3 meaning there's a crown and then there's some pink porcelain to correct, if you like, the dimensions. So this is an immediate placement placed elsewhere. Patient's not happy, and the dentist who treated this case referred to me asking if I could do some gingival grafting to fix this. And of course, I assessed the patient, and I can understand why she doesn't like it, because when she smiles, she sees this pink blob, which she doesn't like. So I noticed that this was cement retained, and that usually is a telltale sign that the implant wasn't placed in the ideal position for screw retention. I notice also that the distal papillae looks a lot shorter and a little bit resorbed. The CBCT shows the implant is inserted where the bone is, so that's what we always would like to do as surgeons. We'd like to insert the implant where the bone is in order to get that primary stability. But it means that the crown, usually in the anterior maxilla, cannot be screw retained due to the anatomy of the anterior maxilla. But the issue here is that the implant is also placed two buccals. So you'll see here this pink line, which I've drawn here, shows the axis of the implant. And if this was to be screw retained, the screw access channel would be on the labial aspect. But bodily, the implant is actually placed slightly buccal too. So fundamentally, the implant's in the wrong position. So I explained that the implant should be removed and replaced with a new one. So we proceed to remove the cement retained crown, just with some forceps, just wiggling the crown off. And we see that with cement retained implant crowns, it's very difficult to prevent cement spill. You see here in this case, the cement is right up the gingival margin. And you can also see how buccally placed this implant is, and that the angulation, unfortunately, is off. So the technicians have had to mill this implant abutment in a way to allow a crown to be fitted to this implant, but it means that the gingival margin is off. So then we remove the abutment and it leaves us the implant. And again, another view showing how buccally placed and bodily placed this implant is. It's slightly buccal, it's not in the right position. So we get the correct componentry to remove the implant. And it's always a sad day when we have to remove implants, but sometimes it has to be done. Patient was a very nervous patient as well. And you will hear it, usually you heard the click earlier on as the bone and the implant separated. And the implant is removed. So now I raise a flap. I raise the flap in this case because I want to see what everything looks like in the buccal aspect. I now have a better idea of what the bone is like and where the osteotomy site was before. I start now preparing where I would like to place this new implant. And you can see here that typically to place the implant in bone in the anterior maxilla, the angulation would be incisal. Okay, so this is showing you exactly where the implant would go. Once I've prepared everything, I get my inverter implant ready, the aggressive taper to get my primary stability. The implant is placed. in the ideal position, the ideal depth. And again, the driver showing the future screw retention position. The depth of the implant, of course, depends on soft tissue thickness. As a general rule, you want about 4 millimeters of gum and bone above the implant platform. So you would want to measure everything before you start, of course, and you would place the depth of the implant as required. Although I have no issues with placing implants deeper. The problem is when it's not placed deep enough. So you'll see here that the coronal aspect of the inverter implant is narrower, allowing space for a graft. So we proceed to actually make the temporary crown. In this case, I used a vacuum stent. We designed the temporary crown in a way which would support the soft tissues and allow the future gum position to be improved. And then we graft. We put a healing abutment in place and we graft. In this case, we use 2 layers. So the first layer is set for about 3 minutes. I never really need to set any more than that. Some colleagues tell me they need to wait longer, but 3 minutes is adequate. And then I placed a second layer. Probably overdid it, but sometimes I just pick up a hand instrument and scrape away some of the EthOss. And this is the appearance of set EthOss. If you can touch it with an instrument, it feels, like plaster. So it's not solid, but if you touch it, it's hard. And then we suture up, move the gum into a better position. And then when I remove the healing abutment, you'll see the set EthOss is, supports everything. Typical view of what a set EthOss looks like. You can remove it and the channel remains stable. We place my temporary crown and, you see it's maybe a little bit more plumped up, which is okay. We use non-resorbable sutures because it reduces inflammation, and that's key when we're bone grafting. And of course, with immediate placement, immediate temporization, very, very important to check not only occlusion in the retruded contact position, but excursive movements as well with anteriors. And you'll see here on the left-hand side that the incisal edge of this temporary crown is taking all the load. So we reduced it slightly so that it's balanced with the upper left one as well. And again, another post-operative radiograph showing the inverter in place, but also just how much better it looked already on the day of surgery, and the patient was delighted. Now, the patient travels a couple of hours to my clinic. So far, I've asked her to send me some photos, just herself, to let me see how everything is going. I checked her out in a week afterwards and removed the sutures, so it kind of looks okay. 6 weeks later, you'll see how healthy the gums look and how much better the gums look already. And this was actually a recent photograph that she took. Unfortunately, not very clear, but the soft tissue margin already much, much better. So this case teaches us that the position of the implant is crucial with immediate placement, and having the correct materials to graft as well. Very nice material like EthOss, keeps everything nice and stable, very biocompatible. So I'm looking forward to see her. I think she's coming back to see me in the next couple of weeks. If I have an opportunity to share some photos with yourselves, I will do that. But yeah, a very, very promising case so far. Now we're going to move on to full arch treatment. As you can imagine, it's not possible to cover everything about full arch treatments in such a short time, but I thought I'd take the opportunity to go over a case which is not, again, complete yet, but involves some pre-implant bone grafting with EthOss and it's a fully guided case with a system which I helped develop with Southern Implants. So before I show you that case, let's summarize how I carried out full arch treatments for many, many years. This is Helen, and she has a failing dentition, and it's due to the history of neglect and periodontal disease. This is actually a dual arch case, but we're staging it. So for the upper arch, we're extracting all her teeth, grafting, and providing her with an immediate full removable denture. But in the lowers, we removed all her teeth, placed implants immediately, and immediately loaded. So this is typically how I carried out freehand full arch guided surgery. We would make stents up with our remaining teeth. We would remove the teeth, carry out any bone reduction as required, cleaning the bone, removing the infection, and using our guides from the teeth that we had before we took them out. We start placing implants into the position which we prefer. You'll see here there's a 12-degree angled pin, some straight implants, straight pins. So we place the implants, and then we do a chair-side conversion using what, like we can use our denture, we can use something that's, a denture that's made for the case. But in this case, I used some blue mousse and seated that into the mouth and highlighted where these implants are. And then we recreate holes in the denture. And then we insert some temporary cylinders and we pick up these cylinders using self-cure acrylic. And we can go from something like the left-hand side of pre-op to the post-op. So the upper at the moment is a full denture and the lower is an immediately loaded full arch lower bridge. So a very acceptable result, and that's how we did it. And by doing it that way, there's nothing wrong with it, but typically takes a long time in the surgery with my technicians on site, etc. So now, about 3 or 4 years ago, I was one of few clinicians who helped trial Southern Implant's guided surgery system, the Cyreal system, and I was the first in the UK to use the system in a patient. And with many successful cases, I thought maybe we could use the same technology and expand it into full arch treatment. Can we make full arch treatment a little bit more predictable, accurate, and efficient? By the way, this is an AI-generated version of myself. I asked AI to create an image of Michael Tang. He's a dentist. He's in deep thought in his surgery. So I think AI did pretty well. So we've got a failing upper arch. Let's show you this case that I'm talking about. It's a staged approach, grafting first with EthOss and implant insertion several months later. So I'll give you this short video to explain how this guided system works. So this has what looks like a mandrel. We call it a cannon. And the kit consists of very few components. Predominantly the cannon and these offset sleeves. They almost act like drill stops. So the different drill stops insert into the cannon. And your drills would fit into this mandrel, this cannon. And we rotate this little swivel lock to lock the drills in place. And easily removed. So as part of the planning process, we will decide which offset sleeve to use and how deep to drill. So with the position of the implant designed prior to the patient coming in and having all the guides made up, we now have this guide system whereby the position of the drilling and the implant placement is all determined by the guides. So the depth is controlled by the drilling with the mandrel. The mesial distal buccolingual positioning of the drilling and the implant placement is controlled by the guide itself. And once the osteotomy is prepared, your implant is inserted through the guide to the correct 3D position. So back to the patient. She's had lots of treatment over the years, crowns, root treatments, typical bridges, extractions, denture. And now a couple of other teeth have become symptomatic. There's areas in some of these, deep pocketing. And having discussed, again, the usual options, she decided with an upper clearance and a full upper arch implants. Now, the ridge looks good. However, when we took the CT scan, you will see that the ridge is actually really thin. Okay. And you can see that when we raised the flap, when we did the surgery, very, very thin ridge there. So what we did in this case was we did some bone grafting before the implants were placed. Again, key thing is cleaning the bone. The bone needs to be really clean. No soft tissue tags, nothing like that. So I use the degranulation burrs, then some sharp instruments to clean. And then I like using the EthOss within the tube itself. So we mix the EthOss in the tube to the consistency I like. And then we place the EthOss directly onto the areas I want to graft. Now, because of the consistency of EthOss, you can actually start, molding the EthOss into position. We start setting the initial bolus of EthOss on the left. So that is 3 minutes. And whilst that's taking place, we're going to place some EthOss on the other side and start molding that also. And then we start setting the right side, and you'll see the left side's already set. So we're going to go back and forth, left, right, adding more. Starting to mold the left again, and this is the first layer on the right. So basically just slowly, layer by layer, we build up the EthOss to correct the bone defect. So we suture up, close up, and we leave it for 4 months. Then we start the planning process for the full arch guided system. Usual, full set of photos, both retracted and non-retracted. I'm going to speed up a little bit because I know we're tight for time. We need some intraoral scans, new CT scan, and you'll see the EthOss, sitting there, behaving itself. This was, I think, 4 months later. So the planning takes place behind the scenes with some planning software. We use co-diagnostics, and we come up with a wall planner like this, which we put on the wall on a day of surgery. We can refer to. And we have the guided system here, and this is a printed carbon fiber. And again, this is the first case in the UK, as we like to try these new things. And we have everything all set up, chair side. And look at the bone. So on the left side, we have the pre-op. This is before the bone grafting, how narrow and thin this ridge is. And look at how plump this bone is now. Bleeding bone. So this is regeneration. This is amazing stuff. Now, with the guide, again, this is another few hours of chat when we talk about guided surgery, but we have the guides in place where we fit over the teeth. Then what we do is we drill holes to actually fix this base plate in place. This is the kind of carbon fiber base. And we use these pins to secure this base onto the ridge. Now, everything thereafter is based on this fixation base. We place this drilling guide onto this fixation base, and all these little sleeves are where we're going to be drilling through using our Cyril system. So we put various drills onto the mandrel, and we drill to depth. We can't go any, the position is set. Okay, the depth, the position is all set. Once we've completed that, we move on to a different guide. And this is a placement guide. So you'll see these little markers here. These are round for our straight implants, and these are more oval for our coaxial implants because, of course, the insertion angle is different from the screw access angle. So we would place the implant to depth. This is the carrier. All to depth. Okay, so the correct depth, correct angulation. And you'll see here that the insertion angle is here and the prosthetic screw channel is 12 degrees difference. So that's it. All the implants in place. We remove all the guides. You see all the implants in the correct position in the correct depth. Multi-units are attached. Then we start making or transferring the prosthesis onto the implants because the bridge is also pre-made, pre-designed. So only it fits into the base. So there's no other position that this temporary bridge fits. We pick up all the cylinders. We cut off all the little arms and polish up. And in this case, I added some more graft. Patient is sutured up. And we fit the temporary bridge. So a nice result. So this is what we call an FP1 case, where the teeth are of the correct shape and size, sitting on the gum without any pink and without the teeth looking elongated. So the FP1 is where the teeth, there's no pink, the teeth sit on the gums. FP2 is where the teeth look longer. And FP3 is where we have to use some pink to mask the fact that it's not quite the right size. So a good case with this one. It's not fully restored yet, but as I said, it's a case where we tried using the new carbon fiber printed guides. And just to wrap up, people ask me about post-operative care. So this is things that we talk about. Analgesics, I give nothing more than paracetamol or ibuprofen. Oral hygiene, we always talk about manual brushing. I do not like patients using the electric toothbrush and vibrating and buzzing away because I find that it disturbs the area too much and it may disturb the ethos. Mouth rinsing, not really essential, but if they want to, just very gentle salt and water. I don't routinely give antibiotics unless I'm worried about some infection, but I don't routinely give it at all. And for full arch cases, I give dexamethasone, 8 milligrams in day 1, 6 milligrams in day 2, 4 milligrams day 3, and 2 milligrams day 4. So reducing dose, but I only do that for full arches or sinus lifting. And also a very soft diet for these cases. So I hope I've given you a flavour of how I use EthOss and how I manage certain implant cases. And I am happy, if we haven't run out of time completely, to take some questions that you may have. Thank you.
Thank you so much. That was absolutely amazing. And I'm sure everyone appreciated the cases that you've hand selected to show them. So thank you very much. Now, you were super thorough. We don't have a whole load of questions, but we do have some. So I will read them out for you. The first question was, you said that 99% of your implant/grafting cases are Southern/EthOss. What are the 1% and the difference, and why do you choose differently?
Okay, so implant-wise, the 1% that I use, if I don't use Southern, I use Straumann BLT. And it's a fantastic implant system, but Southern Implants has all the implants and all the different types and all the site-specific implants that I require, but I use Straumann BLT because in some courses that I teach, they are sponsored by Straumann, therefore I have to use Straumann. So that's the 1% where I don't use Southern Implants for my implants. EthOss, typically I find, and it's in my hands, and it's perhaps just what I'm comfortable with because it's always what I've done, is large sinus grafts. I like to use a sticky bone. For those who are not familiar, sticky bone is when you take bloods, you spin down the blood. It's basically PRF, and you mix the fibrin with whatever graft material you choose. And typically, I like to use pig bone for my sticky bone for large sinus grafts.
Okay, that may answer the next one, but the next question was, during your case selection, when would you not find EthOss to be the appropriate graft material? So sinuses would be one, which you've gone over. Would there be anywhere else that you could talk
So
about?
Yep. So many of my colleagues, I mean, that's in my hands. Many of my colleagues use EthOss for sinuses as well, without any issues. Um, but it's one of these things where I know that I want to make sure that I've just done it over many, many years, and xenograft in the sinus works well for me in the sticky bone. EthOss otherwise works fantastically well in all other cases. In bigger defects where you need to use maybe 3 layers, 4 layers, then typically I use the tenting technique. I use the 2O PDS sutures. Again, we probably won't have time to show you images, but I use tenting technique to actually build up the EthOss. And however, with bone grafting, the bone defect really needs to be within the bony envelope. So it's not, EthOss is not this kind of magic powder where you can bulk bone up everywhere. You have to recreate biology. So if the biology dictates that the bone shouldn't be there, then you can add as much EthOss as you like, but the EthOss will disappear because it's not within the bony envelope.
Lovely. In your second maxilla case, did you give the patient a provisional on the full arch?
The full, say that again, the full arch case, yes, they're all.
Yeah, the full
Oh,
arch.
when I did
When
the,
you did the
sorry,
grafting? Yep.
when I did the grafting, yes, yes, I did. The patient, I used the patient's existing denture, which I modified and eased so that it didn't apply pressure onto the grafting area.
Okay. And the last one that we'll read out this, and I've got a couple, I've got heaps coming through now. So, in your hands, do you use the gauze completely dry when setting EthOss?
Yes, I do. I find that's the best way that it works. So completely dry, so that it can absorb any residual moisture, any saline that's on the graft. So that's the only way it sets. Otherwise, I find that it doesn't really set well.
Okay, the next one is once you've cleaned and degranulated your bony site, do you make perforation holes before placing implants, EthOss for vascularization?
No, that's not necessary at all. And in fact, when I perforate, I've tried them. I've tried all the different ways of working with EthOss. If I perforate the cortical plates, of course, in theory, you want some bleeding. You want the blood to come out. To start to mix with your graft. But in EthOss, that's not necessary. And in fact, of course, it may prevent it from setting. So absolutely not necessary to perforate the buccal plate, the cortical plate. Place the EthOss straight onto clean bone.
Okay. When you are grafting and widening the ridge, how do you create or achieve a tension-free closure with soft tissue?
Okay, so the key thing is minimal damage to the to the periosteum. So in an ideal world, what you want to do is one clean, deep incision to release the periosteum. With EthOss, you do not want to use things like Shukron brushes. I'm not sure if you have Shukron brushes in Australia, but
Not
I
sure.
have a set, and I used to use them a lot, but it doesn't work with EthOss. So with the Shukron brushes, it's designed sorry, designed to be a safe way to release the periosteum, and it works very well. However, if you damage the periosteum, you've lost that bone growth potential. You've lost all the goodness of the periosteum. So one deep incision to release the periosteum is ideal. But you do want adequate release because, as this person that's asked the question, you do not want any tension to the soft tissues.
Okay. Here's one, I'll read this last one and I'll let you go. We might have a couple that we send over to you for a written response. When placing you said when placing EthOss within the bony envelope for it to be successful, how about when there is a buccal defect? What happens to the gum to EthOss interfaces?
So, when there's a buccal defect, what happens to the gum? I'm not really 100% sure what this means. So there's a buccal defect.
Buccal defect. What
Mm-hmm.
happens to the gum to EthOss interfaces? We can do a written
But
response to it if you like.
yeah, as I said, I'm not quite sure what this means, but if you raise a flap, there's a buccal defect. The same, we clean the ridge, we clean the bone, remove any soft tissue that's on the bone, any infection, any soft tissue tags on the bone, make sure it's hard, clean, apply the EthOss as I suggested, whether it's 1 layer, 2 layers, or using the tenting technique. And then you simply put as long as it's tension free, you put the soft tissues back together again, and there's no issues.
Excellent. All right. We might leave it there, and I think I've got a couple of questions to send over to you, and we'll get some written responses. But thank you so much for your time. That was an absolutely wonderful webinar, and I'm sure we're going to get a lot of post traction and possibly could get questions coming in for you. So I hope you're ready to get a couple of emails.
Yeah,
But
Ash,
yeah,
I'm more than
thank
happy
you.
to. Yeah, I'm more than happy to answer any further questions via email. Ash, just send them to me, and happy to receive any questions directly as well.
I will do. So anybody that's still on that has further questions for Michael, please feel free to send them through. And we will endeavour to get the answers to everybody as quickly as we can. But yes, thank you very much for this evening. That was wonderful, like I said. And that wraps us up for this evening. So you can head off into your meeting-filled Admin Wednesday while we all get ready for dinner and bed over here.
Thank you very much, Ash. Have a
No
good evening.
worries. Thank you very much. See you.
Bye bye.